Hola, buenos días. Estamos aquí con el doctor Sean Collins. Él nos acompaña de la Universidad del Sur de Florida. Él es radiólogo oncólogo y tiene mucha experiencia en el área de urología oncológica. Sus áreas de experiencia o de mayor expertise son cáncer de próstata, cáncer de vejiga, cáncer de riñón. Entonces, el día de hoy vamos a platicar un poco con él. So, hello, Dr. Sean Collins. It's a pleasure to have you today here with us. And thank you for accepting the interview.
To me, coming and visiting Mexico, I am so happy to be here. This is my first time in Guadalajara.
Okay.
And let me tell you, the people in Mexico have been so nice to me.
That you will come back.
You might never get rid of me.
Okay, that's perfect. So I would like to ask you, we were talking about that you have a lot of experience with the prostate cancer. Can you tell us about which is the most application that you do for prostate cancer in the radiation therapy?
Great. So when I was young, 20 years ago when I finished residency, my favorite doctor was Michael Zalewski, and he used to treat patients with 40 to 45 fractions of daily radiation for prostate cancer. Then my father got prostate cancer, and my father was an Irish immigrant. We lived in New York City. He went and met Dr. Zalewski, and he said, that's nice, but there's no way I'm getting 45 fractions of radiation, and he went home. So I started being a radiation oncologist at Georgetown University in Washington, D.C., and we had the absolute worst parking in the world. We had a brand new machine called the CyberKnife, which is the most accurate radiation in the world. It tracks prostate motion as it treats, so you can treat with smaller margins, and it allowed us to do 5 fractions of radiation for prostate cancer versus doing the standard 40 to 45 fractions. And by the way, patients really liked it. To me, being in Washington, D.C., there's lots of traffic. Men in the United States are living longer, so instead of hanging out in the clinic with me for 45 fractions, they chose a 5 fraction approach where they could spend more time with their grandchildren and traveling the world versus hanging out and getting radiation.
Yeah, sure.
So I got to admit to you, the first time we started doing 5 fractions of radiation 20 years ago, it was a little bit nerve-wracking, because we'd never done it before. But I had just finished a PhD at the University of Michigan, and I was really into doing research, and quality of life questionnaires were just coming out at that time. So we treated every patient we used quality of life questionnaires to assess their baseline urinary bladder sexual function, and then followed them for the rest of their lives. So I followed 2,500 men for about 20 years and gave all of them quality of life questionnaires. And what we found out is that 5 fraction of radiation is actually very well tolerated. Improving the accuracy of radiation actually reduces bowel side effects. And actually, compared to brachytherapy or the radioactive seeds, SBRT actually had less urinary side effects.
Okay.
So to me, I feel like I've achieved at least one thing in my life. I've published over 100 manuscripts on prostate SBRT. Michael Zalewski, my favorite radiation oncologist in the world, now does SBRT on everybody, so I feel like I helped convert him.
Yes.
And so I think it's better for the patients, and I'm really happy with what I've done so far.
Okay, that's so interesting. And during this following up of more than 2,000 patients, which are the most common side effects that you have seen, in short and in a long course?
Okay, so it's so funny because when you follow that many patients and you give them questionnaires, you actually, I think a lot of doctors don't even ask how their patients' side effects are. So to me, I know really well when you get 5 doses of radiation to your prostate, you will have acute urinary symptoms for about 3 months.
Okay.
Burning and straining can happen. We put everybody on Flomax is the medication, or tamsulosin in America that we commonly use for straining to urinate. Works really well. About 10% of the patients need a short course of steroids to decrease the swelling in their prostates. The burning usually goes away quickly. The urinary frequency urgency usually takes about 3 months to go away.
Okay.
Since we're using very tight margins, we rarely have a lot of bowel side effects. So men used to get severe radiation proctitis with radiation. Now men, when they get radiation, we always treat them with an empty rectum. They do a low fiber diet. We make them do an enema before each treatment. But they rarely have significant bowel side effects. Maybe 10% of them will need Imodium,
Okay.
1 a day for a couple of weeks after treatment. but no long-term bowel frequency urgency. Rectal bleeding is really rare with modern SBRT for prostate cancer.
Yes.
Unfortunately, the prostate is a sexual organ. So when you radiate the prostate, there are changes in your orgasm, changes in your erections, changes in ejaculation, and men definitely have a decline in sexual function after treatment. The good news is that Viagra, Cialis, and Levitra are highly effective. So if you have a guy who is having whose penis worked before treatment and a year and a half later it doesn't work, they have a 90% chance of Viagra working.
Okay.
So, and usually you don't lose all your ejaculate. Usually only 10% of men have anejaculation.
Like forever?
Forever.
Okay.
90% maintain some ability to have ejaculation.
Okay.
So
well, that's a huge percentage.
For them, it's a big deal.
Yes.
I mean, for us, we're like, they're old men. Why do they care about that? But for them, it's a big deal.
Yes, I know. And okay, so in this long course that you've been following these patients, also have you seen that they recover the sexual function, or not just the problems in ejaculation, but like maybe it's more when they have been like recently irradiated than in 10 years? I don't know.
I mean, it's really sad, actually. I mean, I do feel bad that like most men after radiation will have a decrement in sexual function. I mean, they're aging anyway, so they can have a decrement in sexual function anyway, but it doesn't recover. Like your ejaculation doesn't recover, your erectile function doesn't recover.
Just like in surgery.
Just like in surgery. So they get, maybe it's not romantic, but they get used to Viagra, Cialis. The highly motivated men will do penile injections when the pills stop working. The highly motivated men will do penile implants when they stop working. But
yes.
So for the highly motivated patient, I think the urologist, by the way, the urologists in Tampa at the University of South Florida are spectacular. Do a great job of helping our men who are suffering due to erectile dysfunction due to radiation.
Yes, we'll help with that.
Yes, I mean they're very helpful.
Okay, and do you have some experience, like right now we know, like in the oligometastatic disease for prostate cancer, like which are the outcomes that you have seen and the most application, like in which type of disease? Because we have problems like defining which is the oligometastatic disease, which patients gets better, with how many lesions, and how do you define this disease?
So the radiation oncologists, if they follow their patients, like they behave like they cure 100%, but if you follow all of your patients, 30% of them will fail years later.
Okay.
They almost always fail in the pelvic, upper pelvic, lower abdominal lymph nodes.
Okay.
Okay. And they usually it's only a few lymph nodes. We've only had PSMA PET scans in the United States for about 3 or 4 years. You guys have probably had them for 10 years.
Yes.
But, so
a little bit longer.
Right. So once I got the PSMA PET scan, I started treating all of these nodal oligo recurrences with 5 large doses of radiation, SBRT, combined with hormonal therapy. And the nice thing is I used to do 6 months of hormonal therapy. We now have pills in the United States which give men more control.
Oh, yes.
So in the United States, it's called Regulix or Orgovix.
Yes, the antagonist.
Yes.
Yeah, we don't have that in Mexico.
It's really nice because the injections never wear off. Giving the pills to patients.
And monthly, it's some like,
oh my
they don't
God,
like it.
They don't like it. But men, a lot of men are frightened of injections.
Yes.
So they prefer the pills. So we're lucky we have the pills. And the nice thing is, I always tell the men, we'll do 6 months of hormonal therapy. We'll do radiation for these nodal oligo recurrences, which I think have better prognosis than bone oligo recurrences. And but they'll stop the hormonal therapy. I'll say 6 months, but if I get 3 months, that's better than no months. And for the men who are like, well, it's not bothering me that much, we do 9 months.
Okay.
And we don't cure. I mean, we probably cure like 10% of them, but at the bare minimum, we kick the can down the road. And all these patients are like 70 years old. Like I don't usually do radiation on 50-year-olds. The surgeons usually operate on them. But the 70-year-olds, I mean, a lot of 70-year-olds in America, if you kick the can down the road long enough, they die of something else.
That's true.
Actually, I had a patient the other day die of a massive heart attack, and his PSA was rising. But I was like,
he didn't.
It wasn't, it's kind of like, oh, good, he didn't die of prostate cancer.
Yes.
but we had treated him a couple of times, and
he did die of another thing.
He died of another thing.
Yeah, we
by the
always
way,
say
I had
that.
no idea. I had no idea he was going to die of a massive heart attack. My definition of oligometastasis is I hate the number definition. Like I have a PhD in biochemistry.
Okay.
There's no way you're convincing me that someone with 6 lymph node metastasis is different than someone with 5 lymph node metastasis. So my general rule is if I can treat them in a single field, that's probably oligometastasis.
Okay.
If you have 5 bone metastases, one's in your rib, one's in your back, I usually don't do it. Okay. And I usually refer them to medical oncology or urology. And they're getting much better at giving them multi-agent hormonal therapy and or giving them chemo early or
radiation therapy.
Right. So, but the nodal oligorecurrences, I think we definitely do help them.
Okay. So all this is very interesting. Thank you so much for all this feedback.
Yes.
And just for the last question, I would like to know, you were talking in the conference earlier about the SBRT in renal cancer. So which are your final points about the treatment of small renal masses with SBRT?
So first of all, I am not a urologist.
Yes.
Okay. I do not decide when a patient needs treatment for a small renal mass. That's your job.
Yes.
Okay. So if a patient needs treatment, but is not an ideal candidate for surgery, like you guys have patients that you're like, oh, there's no way I want to do surgery on this person. They're morbidly obese. They have too many health problems. But once you tell a patient they have a renal mass, that makes them anxious. So if there's a patient that you think needs treatment that's not a candidate for surgery, and who is either the tumor is too large for cryoablation or the location is near a blood vessel and is not a candidate for cryoablation, I think that patient is a good candidate for SABR or SBRT, which is usually 1 to 3 large doses of radiation.
Okay.
It's completely non-invasive. I lay the person on a table. I get a CT scan with oral contrast. I do put a belt around their abdomen so that when they breathe, their kidneys don't move.
Yes.
Yeah, their kidneys don't move. But usually they come in, they get the scan, they come back 2 weeks later, most of the time they get 1 treatment, sometimes they get 3 treatments. Maybe they have a little bit of nausea, they go home, and then we follow them and their tumors get smaller.
So it's really pretty safe for the patient.
I mean, it's really safe. Now, I wouldn't do it on a healthy 50-year-old because following small renal masses that have been irradiated, they usually get larger first and then get smaller. It's called pseudo-progression.
Okay.
And plus, contrast enhancement doesn't help us determine who is going to be, who's responding or not responding. I'm hoping that new things like PET imaging for renal cancer, which is coming out in the United States probably in the next year or so, or this circulating tumor DNA will help us be able to better follow these patients. Right now, and by the way, our follow-up's only 5 years. So like a healthy 50-year-old with a 6-centimeter renal mass needs needs a partial nephrectomy.
Yes.
A 75-year-old with a 6-centimeter renal mass who's got congestive heart failure on anticoagulation, if you're going to choose observation or nothing, then why not give them SBRT or SABR and at least have some treatment for the tumor?
Yeah, that's completely right. I agree.
Yes.
So thank you so much, Dr. Collins, for all your sharing this knowledge. And well, we'll see you, I'm hoping, in another conference.
So the conference next year is where?
We don't know yet.
We don't know yet.
No,
okay.
But we'll tell you. We'll
okay,
let
great.
you know.
Perfect.
Thank you.
Thank you. I love my urology colleagues. I tell you, you guys throw a great meeting. I'm having a great time. Thank you for having me.
Thank you for coming.
Great.
Well.